يعطيكم العافية جميعا. اليوم المحاضرة تبعتنا راح تكون عن Class 1 Malocclusion, and this is going to be the first series in the lectures for the managing of different types of malocclusion: Class 1, Class 2, Division 1, Class 2, Division 2, and Class 3. So what we're going to do today is to cover definition, etiology, and features, and the management of patients with Class 1 malocclusion. So what is Class 1 malocclusion? Basically, you have a patient where the incisors, edge of the lower incisors, occlude below the cingulum plateau of the upper incisors. And the cingulum plateau, as we discussed previously in fourth year, is just above the cingulum, about the middle third of the upper incisors. And this is the classification issued by the British Standard Institute. So basically, these patients has a normal incisor classification because we always target to finish in a Class 1 incisors, but probably they're going to have something else that they want to do orthodontic treatment for it. So what is the etiology for Class 1 malocclusion? By the way, we are talking about the etiology. It could be the etiology that resulted in a Class 1, but it could be feature as well, because this patient has, for example, Class 1 skeletal. This means that this is an etiology for this malocclusion, and at the same time, it's a feature for this malocclusion. Whenever we study an etiology of malocclusion, we divide them into three factors: skeletal factor, soft tissue factor, and dental or local factor. So let's start with a skeletal relationship. And as we know, whenever we study skeletal relationship, we look at the anterior-posterior, vertical, and transverse relationship. So what about the anterior-posterior skeletal relationship? So for example, this patient, if you look at her incisors, you can see that she has a Class 1 incisor relationship with spacing, and in the same time she has a Class 1 skeletal relationship, which kind of makes sense. If the patient has a Class 1 skeletal relationship, we're going to end up with a Class 1 skeletal, Class 1 incisors. Now these patients, sometimes they will seek orthodontic treatment for reasons other than the skeletal problem, which is, for example, in this patient, spacing. However, a patient can have Class 2 skeletal relationship, as this patient, as you can see, the A point is ahead of the B point by more than 2 millimeters. But because we have a dentoalveolar compensation, we can see that we have a Class 1 incisor relationship. So when we have a Class 1 incisors, the underlying skeletal pattern in most of the cases will be Class 1, as we can see here. However, we could have a patient with a Class 2 skeletal and Class 1 incisors, simply because the incisors tend to compensate for the underlying skeletal discrepancy. So for example, in a Class 2 here, the lower incisors will procline and the upper incisors will retrocline to reach a Class 1 incisors. The opposite will happen in a Class 3 as well. So the patient will have Class 3 skeletal, the upper incisor will procline, the lower incisor will retrocline, and we're going to end up with a Class 1 incisors. However, in most of the cases, patients with a Class 1 incisors usually have a Class 1 skeletal relationship. So what about the vertical relationship? It's worth mentioning that the vertical relationship has nothing to do with the etiology of this kind of malocclusion. However, it's just a feature. And what I want to say is, in a Class 1 patient, sometimes we will have a patient with an open bite, simply because here we have to focus that we are studying Class 1 relationship is an anterior-posterior relationship. However, the open bite, as we can see in this patient, is a vertical relationship. So when we have an anterior open bite, like this patient here, we drop an imaginary line going from the lower incisal edge, going up, and see where it's going to hit in the upper incisors. And if it's going to hit below the cingulum plateau, then this is a Class 1 incisors, as is in this patient. So patients with Class 1 might have an anterior open bite, and in the opposite, they might have deep overbite as well. And they could have a normal overbite. These are all vertical features for the Class 1 malocclusion. So what about the transverse relationship? Again, patients with Class 1 incisors, they will have a normal incisors relationship, but they might have a crossbite posteriorly, a posterior crossbite. And the reason for this crossbite could be skeletal or could be a local factor due to the path of eruption of the upper premolars and molars, and we're going to discuss this later on during this lecture. However, so patient with Class 1 incisors could have narrow maxilla resulting in a crossbite and could have a normal occlusion with no crossbite. What about the soft tissue as a factor? Soft tissue in a class 1 malocclusion, they help us to compensate. So they are kind of helper to compensate for the underlying skeletal discrepancy. If you can see this patient here, he has a class 2 skeletal. But because of the lips, especially the upper lip, they can exert pressure on the upper incisor to retrocline them. And the tongue exerts some pressure on the lower incisors and result in proclination of the lower incisor, resulting in a class 1 um, incisor relationship. So soft tissue are favorable in a class 1 patients. Some patients might have low tonicity of the lips, and that will result in protrusion or proclination of the upper incisors, and that will be bimaxillary protrusion. We're going to discuss this in the end of the lecture as well. So what about the dental factor and the local factor? Actually, this is the main factor for the malocclusion class 1, because these patients, usually they have class 1 incisors, which is our target always to finish in a class 1 incisors. That means they have a normal incisors relationship. And as we said, most of the time they have class 1 skeletal. And even if they don't, the soft tissue will try to camouflage them into class 1. So usually we don't have a problem with the soft tissue or the skeletal, but we will have a dental or the local factor. And that's why the patient will seek the orthodontic treatment. As we can see here, the patient has a class 1 skeletal and she has a class 1 incisor relationship, but she has a spacing between the front teeth. So this can be a cause why the patient will seek orthodontic treatment. Crowding as well. So if you can see this patient here, due to the tooth R size discrepancy and the canine are the last teeth to erupt, they are displaced buccally. So basically the patient has crowding due to the tooth R size discrepancy, though she has a class 1 incisor relationship. And that's why the patient now is seeking orthodontic treatment because of the local factor. Premature loss of a primary tooth, as we can see here, will result in impaction or ectopic eruption of the canine. So as you can see in the top left, the canine has erupted buccally. And the reason for that, because there's no space for the canine to erupt. And again, the canine is the last tooth to erupt. We had a premature loss of primary tooth, especially the E, I think in this case, resulted in a mesial migration of upper left 6 to take all the space remaining for the 5. The 5 erupted before, the 4 and 5 erupted before the canine, so that when the canine erupt, there is no space for it, and that's why it's buccally displaced. And again, the patient here has a class 1 dental relationship or incisor relationship, but he has crowding that needs treatment. So what we're going to discuss now is the management of patients with class 1 incisor relationship. So as we said, this patient has a normal incisor relationship, and the reason why they seek orthodontic treatment is for different local factors, and we're going to discuss now each of these local factors. The first of which is crowding, as this patient is. So if we have a crowding, now the patient, they don't like the appearance of their teeth and they seek orthodontic treatment. And as we said, the etiology for this crowding could be tooth arch size discrepancy or could be premature loss of primary teeth. So let's see how do we manage this patient. This patient has a class 1 skeletal, as you can see, and if we go intraorally, we can see that she has severe crowding, that the canine is now totally displaced buccally. Now the question is, are we going to treat this patient with extraction or non-extraction to treat this malocclusion? Now, having the decision of taking out teeth or not to align crowded dentition has been debated for years in orthodontics. However, there is certain factors that we need to consider when we decide to extract or not. The first of which is the amount of crowding. So patient like this one in the top left, as you can see, the canine is completely displaced, which means that you need at least 9 mm of space at that side to align the canine. And on the opposite side, the canine is buccally displaced as well, but the amount of space required is almost 2 to 3 millimeter, which means that we need 12 millimeter of space in the upper arch just to align the canines. This is severe crowding. So when we have a patient like this, then we have to go for extraction because it's too much to extract non-extraction treatment in the patient with severe crowding like this. Other factor to consider as well is the midline shift. So if we have a midline, shift to one side, we tend to extract on the opposite side to correct this midline shift. We have to look as well for the incisor inclination. So, if we have a patient with crowding and we decided to treat him non-extraction, one of the ways to provide space is to procline the upper incisors. And as you know from the space analysis, each 1 millimeter of proclination of the upper incisors will give us 2 millimeters of space per arch. So this is a good amount of space, but if we have severe crowding or moderate crowding, then we will have an excessive proclination of the incisors, which is, one, unstable, and two, is not aesthetically acceptable by the patient. So we have to consider as well the amount of inclination of the incisors before we go for extraction or not. So this patient with the amount of the severe crowded was treated in extraction of 4 units, 2 in the upper and 2 in the lower, to align her teeth and to avoid the proclination of the upper incisors. Another patient with a class 1, as you can see here, the profile of the patient's class 1, he has crowding in the upper arch, and if you look at the upper arch, you can see that this amount of crowding is mild to moderate, almost 4 to 5 millimeter, and the same amount of crowding in the lower arch. So this patient is treated with extraction non-extraction treatment. And the reason why, because the amount of crowding is not as severe as the previous case, the incisors are not proclined at the start of the treatment, and the patient will not end up with a bimaxillary protrusion, which means that both upper and lower incisors will be proclined excessively to the point that it will affect the lips and in the same time affect the appearance of the upper incisors because they're not going to look nice when they are proclined. So this is him after we procline upper and lower incisor and treat him with non-extraction. And you can see in the bottom left that we place it above the retainer because as you know, proclination of the lower incisors is not stable. I think you're going to take a lecture about the retention and the relapse. And this is going to be discussed in details, but for the sake of now, for this topic, proclination of the lower incisors more than 2 millimeter has been accepted in many textbooks as non-stable treatment. So whenever you decide to procline the lower incisors more than 2 millimeter, you have to commit the patient for long-term retention. So back to our case here, you can see that the soft tissue of the upper lip has not changed with the non-extraction treatment, not proclined and not pushed forward, and in the same time, if you can see the upper and lower incisors are normal inclination. So these are kind of factors that we consider when we treat a crowded case. Now you're gonna come across late lower labial segment crowding condition quite often. So what does that mean? Patient who is 13, he will have a well-aligned lower arch. Then all of a sudden, before he hits the 20 years old, the lower arch starts to be crowded. Mild, sometimes it would rarely sometimes go to a moderate crowding, but usually it's a mild crowding, like the one seen here in the photograph. So why is that? Why the patient who is 13 years old has a well-aligned dentition, and then during the teenager process, until the age of 19, after he finished 19, you can see that there is a mild crowding in the lower arch. There's many theories that try to explain why we will end up with crowding at the age of 18 to 19, and the reason for that is not clear 100%, but we have multiple factors that are considered together as a reason for the lower labial segment crowding. One of these factors is the intercanine. A lot of studies has been done in human, and what they did is they take records of the intercanine width and see what's going to happen with the intercanine width during the age. And they found that the intercanine width will keep increasing the size in the transverse dimension until the age of 13. And then after the age of 13, the intercanine width start to narrow down until the age of 20. So basically making the room of the lower incisors smaller because it's kind of that the lower intercanine is shrinking a little bit. So this could be a reason why we have a crowding. Another reason is the wisdom teeth. When the wisdom teeth erupt, as we kind of call it, an erupting wisdom, and there's no enough space for this wisdom to erupt, they tend to push the whole dentition forward. And for the upper incisors, or the upper lid and the lower upper incisors, to keep everything in class 1, they tend to retrocline. And once you retrocline the lower incisor, you are moving them from a bigger space into a smaller space, which means they have to be crowded now to adapt to the new situation, and this is why sometimes we get a late lower labia segment crowding. So now, if wisdom teeth has something to do with the late lower labia segment crowding, why not to go for extraction of the wisdom teeth before they start erupting and worsen the crowding that the patient has or the well-aligned teeth that the patient has? The reason for that they did a study about 7 or 8 years ago in the UK. And what they did, they extracted the wisdom, they have all the patients with class 1 malocclusion and well-aligned dentition at the age of 13. And they divided them into two groups. In one group, they extracted the wisdom at the age of 13. And the other group, they just observed what's going to happen. But they found that the amount of crowding in the same group is almost similar. It's lower in the patients with the extraction of the wisdom, but slightly and not clinically significant. So you have now to weigh your action. Do we have to extract a wisdom tooth and send a patient who's 13 years old into surgery to open flap, drill bone, and remove the wisdom tooth for a couple of, or a fraction of a millimeter? That's not significant compared to the group in which we did not extract the wisdom tooth. So now the conclusion that we have regarding this topic is it is not justified to extract a wisdom tooth in order to avoid late lower labia segment crowding. So we don't do that anymore. However, we do believe that there is some weak evidence or that the wisdom teeth can push the lower dentition forward. However, the studies and the strong studies, the randomized clinical trials show that this is not completely true. The other thing that might result in late lower labia segment crowding is the occlusal force. So how is that? Now, when the patient bite, there is a mesial angulation in all of the lower incisors, all of the lower and upper dentition. And then if you study the vectors of the force, we will have, when the patient bite, we'll have two vectors. One is vertical and the other one is horizontal. And because of the mesial inclination of the force, the direction of this force will be mesially as well. Now this direction of the force, it tends to push the lower incisors forward. And because the patient has class 1, there is no room for the lower incisors to move forward. So what they do is to retrocline. And once they are retroclined, we will end up with crowding again. So all these theories are trying to explain why we will have a late lower labia segment crowding. But the most important to know that it's not justified to extract wisdom teeth just to avoid late lower labia segment crowding. And this is as well how we see the patient with class 1 and the lower incisors are retroclined and crowded, simply because they are trying to compensate for any mesial force that move them mesially, either growth or wisdom or the direction of the horizontal vector of the occlusal forces. Sometimes the lips play a role as well, in which they tend to exert the force in the lower incisor to retrocline them. And as we know, retroclination of the lower incisor will result in late lower labia segment crowding. So these are all about you need to know about crowding and the late lower labia segment crowding. What we can do for this patient is just to provide them with a simple orthodontic treatment to align the lower arch, as in this patient here. So we are done now with crowding. We will move to another topic, which is the opposite, spacing. Now sometimes patient, or usually patient with class 1 incisor relationship who has a spacing, they seek orthodontic treatment. So what we can do for them is just to close the spaces. So you move from the top photo to the bottom photo, which is around incisors. However, there is a couple of advantages and disadvantages for using orthodontic treatment to close the spaces. The other option, by the way, before talking about advantages and disadvantages, is to close these spacing using porcelain veneers, or veneers in general. So this is going to make the teeth look bigger. So when we do this or when we do that, when we're going to go for the using the veneers or to orthodontic treatment. So let's see. If you can see the patient in the top, and this photo taken was from Dr. Thamer, thanks for him. If you can look at the top, we have spacing. And in the bottom, this spacing was treated using porcelain veneers. It's nice results. So which one is better? Is it better to close the spaces using orthodontic treatment, or is it better to close the spaces using veneers? This depends on many factors. So let's start with the advantages of orthodontic treatment. First of all, you will not have prosthesis in your teeth for the end of your life or to the rest of your life, which is something you need to think about, especially when your patient is young. So this is one advantage. So what is the other advantage is that you will keep the natural look of the upper and lower incisors, which is I personally like because you need to have something personalized for you. If you're gonna go for veneers, that everyone else in the street will have a similar look of your teeth. I like my special appearance of the teeth, so that's why sometimes I prefer orthodontic treatment. However, it all comes with a cost. So, what are the disadvantages of doing an orthodontic treatment to close the spaces? The first one is relapse, which means that the teeth, after we close the spaces tend to reopen again. And this could be because of the transeptal fiber, because when you close the spaces, the transeptal fiber will be stretched between the teeth, so they tend to pull the teeth back again to where we started. And as again, when you take with the lecture of retention and relapse, you know that if we decided to close the spaces using using fixed appliance, we need to use bonded retainer after we finish because this is an unstable process. So as we mentioned now, we have a disadvantage of the retention. The other disadvantage is if the teeth are small and you close the spaces, then we have a very small teeth, and sometimes you don't see it until you close the spaces. So this is gonna affect the appearance of the teeth, and that's why some patients they don't prefer or we don't advise them to go for orthodontic treatment. So moving now to the option of veneers. What are the advantages and disadvantages and when to use them? So the option of veneers, the first one, disadvantage that you will have a prosthetic teeth to the end of your life or to the rest of your life, which is something you need to think about. The other, however, they have many advantages of using veneers. First one is quicker. Having a veneer will not take you more than a couple of weeks. However, orthodontic treatment, it can take up to a year. It depends on the kind of the malocclusion. The other thing is that the advantage of the veneer is that it can change the shape and the color of the teeth. So if you have a patient with teeth that has been restored many times with composite and you have a multiple staining, then you can consider the restorative option to close the spaces because this is going to improve the appearance as well of the incisors. The last disadvantage of veneers is the space. So if we have big spaces and we decide to close them with the veneers, the teeth will look bigger, mesodistal dimension, which doesn't look great for the patient. So that was us talking about spacing and the different options for managing them when they are in class 1. So the other local factor is the hypodontia, which means the missing teeth. Sometimes the patient will have up to 3 millimeter, we can consider it as a mild, 4 to 6 we can consider it moderate, and more than 7 is considered as a severe. So let's see this patient. If you can see anterior posteriorly, he has a class 1 skeletal relationship, but when he is smiling, there's no upper incisors. These incisors were lost to a trauma when the patient was young and resulted in a bone resorption as well in the upper arch. As you can see that the upper left right 4 is missing as well. It was extracted before we take these photographs. So now whenever we have spacing due to a missing teeth, we will have one of two options. Either to open space and make it enough for prosthetic replacement, or to close all the spaces and reshape the teeth to look like incisors. So for example, for this patient is to bring the lateral incisors to be central and to bring the canines to be lateral incisors. However, to do this, it's a very extensive prosthetic work, plus sometimes it doesn't look nice, especially if the upper laterals are small, because you need to widen the tooth, and this might result in overhang. So whenever we have spacing, we tend to either open the space or close the space We will have a special lectures just to talk about this topic, so I'm not going to go into details. For this patient, we decided to close the spaces of the upper premolar on the right side and to enlarge the space for the incisors for a future implant. Why to enlarge it? Just to look similar, to look nicer, because patient doesn't like to have smaller teeth. So we fitted this patient with TAD, then we used this TAD to move the upper premolar, upper left premolar and molar forward to take the place of the missing four. And then the patient now has space enlarged, as you can see here, and we as well kept space medial and distal to the lateral for future veneers of these teeth because they look very small. Patient went for implant, and before implant he needed a bone graft which he was taken from the symphysis, and then the implant is done. As you can see, bigger teeth than we started, and the space for the upper right four was closed completely by moving the buccal segment forward. Another option of hypodontia is a missing lateral, which is more common than central incisor, because central incisor most commonly is impacted due to supernumerary, and if it's not impacted and it's missing, is due to trauma, as the patient we saw before. However, the more common hypodontia is a missing lateral incisor, as you can see for this patient, who has a coincident midline with the midline of the profile. Looking intraorally, she has a class 1 incisor classification, and she has a missing lateral incisor on one side and a big shaped lateral on the other side. So now we have one of two options: either to move the whole buccal segment on the upper right side forward to close the space, or simply to open space to replace this missing tooth with a prosthetic tooth. You will have a completely separate lecture talking about ortho-restorative on how to reach a decision regarding whether to open space or to close the space when managing patient with hypodontia. So this patient was treated to open space and to distalize the buccal segment, and that's what is done. We distalize the whole buccal segment. The patient has now a bigger space for future implant to be placed here, and the occlusion on the left side is perfectly class 1. And here is the patient after she did the composite build-up for the big shaped veneers, big shaped lateral, and a tooth in an Essex. So basically that was temporarily until the patient get her implant done. Now it's worth mentioning when managing hypodontia, there is something we call it wax up or Kisling setup. So what the technician does, you take an impression and you send it to the lab, and then he sew each tooth individually. So he cut them and make them separate, and then rearrange the teeth together to see whether or not they're gonna fit, or they're gonna fit nicely, and how are they gonna fit. So we talked so far about two things, two local factors with class 1 malocclusion: crowding and spacing. And now we're going to talk about the median diastema, which is something like this. And I'm sure all of you that this is a physiological normal diastema called the ugly duckling stage. So simply, the canines in the upper inside laterals, they've pushed against the roots of the lateral. So the laterals will flare, and then the upper sensors, they will have free room to move as they want. So the median diastema open. Do we have to do anything at this stage? Absolutely not. We just wait for the canine to erupt. Once the canine has erupted, all the spaces will be closed. As you can see here, the canine is pushing against the root of the lateral incisors. So this is one etiology why we will have the hypodontia and the missing teeth, the diastema, Why do we have the median diastema? The other cause is the missing lateral incisors. So when we have a missing teeth, especially lateral incisors, the upper centers, they spread around for the bigger space, resulting in a median diastema. So median diastema could be due to many reasons. One of them, the presence of a conical supernumerary. And this supernumerary, it does not erupt to the patient mouth. It just sometimes, or most of the time, it stays where it is, preventing for the upper incisors to meet or to move across to each other. So in order to, and the other reason for the median diastema is the tooth arch size discrepancy. I mean, smaller teeth than the size of the arch resulting in a space that this is space is between the incisors. Other cause of median diastema is a high frenal attachment. So basically, the frenum is big and it's between the two incisors, and the incisors can't move to meet each other. How to diagnose median diastema due to well-developed frenum is to do the stretching exam. So basically, you stretch the upper lip firmly, and you can see the blanching happening in the incisive papilla, as you can see in the photograph. This blanching indicates that we have a high frenal attachment. And you can see as well in the intraoral radiograph, you can see a V notch where the fibers of goes and bond. However, sometimes we have to provide treatment for patients with diastema. For example, this patient has a median diastema, and then at the same time, she has an in-standing lateral incisors. And this in-standing lateral incisor, when the patient first bites, he bites edge to edge, or she bites edge to edge. Then she has to move the mandible forward to achieve maximum intercuspation. And we can't leave patients like this with displacement, so we have to treat him. And how we did that is to create space for this lateral bite closing the median diastema. And that's what happened exactly. And now we have the four incisors well aligned. So that was an only interceptive treatment for the patient. However, whenever you do, sorry about that. Yeah. It's this one. So whenever you do a treatment for the patient with diastema and in the mixed dentition like this, we have to be careful when we move the teeth, because we don't want the lateral incisor root to hit the canine because it has not erupted yet. Now, it's now agreed that if you have a median diastema of more than 3 millimeter and there's no enough for the space of the lateral incisors to erupt, we can do simple orthodontic treatment just to close this diastema and allow the lateral incisors to erupt. Sometimes the etiology of the median diastema is a high frenal attachment that prevents the two teeth from approaching. So what we can do for that is a frenectomy. Now, frenectomy, when it's first developed, it was used because of the relapse associated with the median diastema. So it was proposed as a method to reduce the chances of the relapse. That was back in the days before we started developing a bonding technology. Now, because we have bonding technology, we can use simply bonded retainer. So the question now, after we place the bonded retainer, do we have to do frenectomy? The answer is not for stability reason. Maybe for aesthetic reason, because patients with high frenal attachment, sometimes, not all of them, they don't like the appearance of the frenectomy and they ask to take it off. The other local factor or local etiology is a displaced tooth. If you can see here that we don't have upper left canine, and it's obvious in the photograph, you can see the bulging in the root of the impacted canine. So what we can do is to align this displaced tooth, simply by creating space and then retracting this tooth to the line of the arch, as we can see here in this patient. We are still in the displaced teeth or tooth due to that resulted in a patient seeking treatment, even though he is a class 1 skeletal relationship. So if you can see this patient, he has a missing upper left central incisor due to trauma. And the patient did not attend the dentist trying to retain the space or provide treatment. So we have a mesial migration of the whole buccal segment in the upper arch forward. And there's no space now for the central incisor. If you take a OPG, you can see the central incisors in the back. However, this radiograph was taken after the surgeon removed the supernumerary tooth that blocked the eruption of the central incisor. So simply what's happened, there is a supernumerary tooth that blocked the upper incisor from erupting, and as a result we lost space of this central incisor, and the patient is still class 1 dental. So what we can do for this patient is to open space for the missing central incisor. We have extracted 4 units, 2 in the upper, 2 in the lower, just to create enough space for the central incisors. And as you can see now, the space is much bigger, and now we will have to bond the tooth and track him down. The other thing is we have sometimes displaced teeth due to the crowding, or what we call it ectopic. And the most common teeth to be affected by this are the canines in the upper, because they are the last teeth to rot, and in the same way the premolars in the lower. So this is the end of first lecture about class 1. Next lecture we're going to talk about the vertical discrepancies.